Hi everyone! Welcome back to Enloe's Facebook Live, where we are coming to you straight from one of our operating rooms. My name is Andrea Gleason, and I'm with Enloe's Marketing and Communications Department. And today I am honored to be with Dr. Keith Cavaness, surgical oncologist with the Enloe Regional Cancer Center. Dr. Cavaness, thank you so much for being with us today.
Thank you for having me.
Absolutely. Now, Dr. Cavaness is going to be sharing some valuable insight for the next 20 minutes on pancreatic cancer, its signs and symptoms, treatment options, and more. Now, for a little bit of background, many doctors call pancreatic cancer the silent disease. Unfortunately, this is because by the time the symptoms are detected, the cancer can already be spread throughout the body. As a matter of fact, pancreatic cancer is the third leading cause of cancer-related deaths in the United States, and it kills more people than breast cancer, according to the Pancreatic Cancer Action Network. Now, before we begin, I just wanted to remind you all that the information we're about to share is not intended to be medical advice. If you have specific questions regarding your health condition, please reach out to your provider. And as always, feel free to leave as many questions as you'd like in the comments field, and Dr. Cavaness will do his best to answer as many as he possible during the broadcast. So, with that, Dr. Cavaness, can you please start by just telling us what is the pancreas, where is it located, and what's its job exactly?
I will. So, pancreas is a pear-shaped, kind of a flat pear-shaped type organ. It's on the left side under the left rib cage behind the stomach. And it's in the retroperitoneum, so in the back part of the abdomen. And the pancreas does two functions. So it works as an endocrine and an exocrine organ. So that means that from an endocrine standpoint, it produces insulin, so it keeps you from becoming a diabetic. From an exocrine function, it produces pancreas juice, which helps digest your food. So with different types of cells in the body, with different types of cells in the pancreas, you can get different types of cancers in the pancreas. And so there are quite a few different kinds of cancers that you can get. So as far as things to look out for with pancreas cancer or pancreas issues, most people complain of pain when they're having issues, and it's kind of on the left flank and under the left rib cage. The strange thing is because of the function of the pancreas and the way the pancreas juice flows, it depends on where your tumor is as to which symptoms you would get. So some people that have tumors that are towards the head of the pancreas, and we typically see in the pancreas, you have the head, you have the body, neck, body, and tail of the pancreas. If you have a tumor in the head of the pancreas, as it gets larger, there are more things close by that it can compress, pinch, and cause symptoms. So people can get jaundice, their skin turns yellow, they can get itchy, they can have nausea. Versus if you have a tumor that's out closer towards the tail of the pancreas, there's actually more room for a tumor to grow and get larger. And as it gets larger, it would have to be quite a bit larger before it can push on things and cause symptoms. But those are some, so that's the pancreas and what it does, and some of the symptoms that we worry about.
Very interesting. Definitely didn't know any of that. So who's at risk for this condition? How is it diagnosed?
So one of the main risk factors that we worry about are people that have a family history of pancreas cancer. So if you have mom, dad, brothers, or sisters, that increases your risk quite a bit of having a pancreas cancer in your lifetime. Other risk factors are smoking. Obesity has a loose risk factor. If you've had pancreatitis before, so if you've had multiple episodes of pancreatitis, or you have a history of chronic pancreatitis, that constant irritation of the organ puts you at risk, and then you could develop a cancer. What are the risk factors? That's all I can think of right now.
Yeah, that's good to know.
So how's it detected? So good question. One of the things that we are finding nowadays is that patients will come into the ER for other reasons, and abdominal pain, nausea, maybe they have a kidney stone, maybe they were in a car accident, and so whatever reason they're coming in, they're getting a CT scan. And those CT scans are now picking up smaller things that they weren't really having symptoms for, but we just caught it incidentally. So we will see these lesions. Of course, if people are having symptoms from cancer, we pick them up because of their symptoms, and they typically come into the ER too. But we diagnose it based on imaging, number one, and then number two, by getting a sample of the tissue. And there's a couple of different ways to do that. the most common way is doing this endoscopy, where a GI doctor will put a scope down. Now, they go into the stomach. They can actually use an ultrasound and look through the wall of the stomach, because the stomach lies right on top of the pancreas. And they can take several biopsies, and those biopsies are what help us to determine if it's pancreas cancer.
Wow, very good to know. And so now I'm just concerned, how common is pancreatic cancer?
Well, so like you said, it's the third most common cancer. What we worry about is, although it's not as common as other cancers, pancreas cancer is a pretty bad cancer to have. It can be very deadly. And so the whole goal in pancreas cancer is trying to catch it early so that we can get treatment as early as possible. Obviously, a tumor that is much smaller, there's the potential for us to have a better impact on their survival than a tumor that has grown larger, or even a tumor that's larger and has spread to other places. The smaller the tumor is, the more localized it is, the more options we have for treatment. And so overall, usually the better the patient does.
Good to know. So as we mentioned earlier in the broadcast, some doctors call pancreatic cancer the silent disease. So can you tell us more about that? What makes pancreatic cancer the silent disease?
Well, so it's kind of like we talked about. It's one of those things where, because the tumors need to grow a certain size before they cause symptoms, those symptoms are usually what sends people to the hospital. So you can imagine if you had a tumor and it was in an area where it can grow to be the size, let's say maybe of a grapefruit, before it actually pushed on anything, that's a pretty big tumor. And so if it's in an area where, like the brain for example, you can get a smaller tumor, and as it grows, it starts to cause symptoms, and so you can usually pick those up as they're much smaller. And so silent, because sometimes we don't know until people come in, and the majority of patients, when they come in and they're diagnosed, they're not really candidates for surgery because it's already grown to be too big.
So what are some of those treatment options?
So treatment usually varies, and often what we try to do nowadays is we try to do, we present our pancreas cancer patients at a multidisciplinary tumor conference so that we have all disciplines involved, and they're able to, so we'll have a GI doctor that may be the doctor that diagnosed the cancer. We have a radiologist there, a radiology team, and they're looking at the x-rays. We have a pathologist that's looking at the tumor cells, a medical oncologist that can offer systemic chemotherapy. So that's one of the options, systemic chemotherapy. Surgical oncologist there, so we can talk about surgical options. We have a radiation oncologist there who can talk about radiation to the area. Most commonly, the way that we address pancreas cancers, and now so everybody, because there's different types of pancreas cancers, everybody always assumes that there's just one, and it's the pancreas cancer. But actually, when we talk about pancreas cancer being more aggressive and the silent disease, and we're talking more about pancreas duct adenocarcinoma. So that's kind of the classic pancreas cancer. There are other tumors like neuroendocrine tumors that aren't as bad and are treated sometimes a little differently. With pancreas duct adenocarcinoma, usually the best treatment is surgery. If they're a surgical candidate, then surgery is the best treatment. And we're learning that sometimes, that often, as we do a multidisciplinary approach and add multiple therapies to something, we get better results. So it's not just one thing fixes everything. Sometimes we're learning that as we treat cancers up front with some chemotherapy, and we can get a response and see the tumor shrink a little bit, then we go in and we take that tumor out. And then they get chemotherapy on the backside after they recovered from surgery, we can improve their prognosis overall. There's still quite a few studies going on, and some of this can be a little, the addition of radiation to pancreas cancer before surgery. Some of this is still being debated in the literature, but we definitely use multi-disciplinary approach to try to treat these diseases. We use, it's kind of like when you're, I guess maybe building a house. It isn't just one tool that builds the whole house. We need to use a lot of different things to make sure we get the best product possible. So.
Yeah, I like putting it in that context, especially because my husband's a builder, so it makes sense to me. So one of the treatment options that physicians are using here at Enloe is the robotic surgery. Now, can you tell us a little bit more about that?
Sure. So robotic surgery is a form of minimally invasive surgery. So the nice thing is that we can often do bigger operations, the same operation that we would do open, we do it through small incisions. So it's funny, they've done studies and they've shown that even though you can have multiple small incisions, let's say you had 5 small incisions and you added up the length of all of those small incisions and compared it to an open operation that could be very close to the same length, patients with multiple smaller incisions actually do better. They have less pain after surgery, they're back to work faster, they seem to have a better recovery. So we're trying to employ that in minimally invasive surgery and with the robot. So we can go in and we can identify the area in the pancreas that needs to be taken out. We can do all of that operation with the robot where we get 3D vision. We can use multiple arms to help retract, and we have lots of different instruments with the robot where we can be very effective with the dissection. And most importantly, we need to make sure that when we're doing the operation, we're doing the same good surgical type of, or cancer type of operation that we would do it. So it has to be the same or better, otherwise it wouldn't work. So these patients, if I do somebody that has a tumor in the tail of their pancreas, we can often send them home on the 3rd day after surgery and they do great.
Wow.
Versus normally if they have an open operation, they're in the hospital for about a week or so.
But still, that's...
It's great.
That's great.
Yeah, patients love it because, you know, we often focus on cosmetic stuff, but the funny thing is, it's rare that I talk to a patient and they're focused on the cosmetic stuff. It's more that they just want to be up active and they want to be recovering sooner. And we found that this really helps them to get there. Now, it doesn't, just because we have a robot, just because we can do this robotically, doesn't mean we can do everything robotically. So you have to be a candidate for the surgery. The tumor has to be in the right spot. We have to be able to do it, like I said, effectively and get the same good surgical margins and do the excellent operations that we know.
That makes sense. That's awesome. Good to know. Gosh, this has all been such great insight. Are there any words of wisdom that you'd like to share before we wrap up today?
Well, I think the most important thing is going to be really identifying if you're at risk. So it's going to be knowing, number one, do you have mom, dad, brothers or sisters that have had pancreas cancers?
Yeah, family history.
Right. Do you have issues with your pancreas? So do you have diabetes? Is it new within the past year? Do you have a history of pancreatitis? Have you been to the hospital multiple times? Do you smoke? If you do, stop. It doesn't matter. There's no cancers that we say, oh, if you smoke, it always makes it better. So that, I think, smoking...
And does chewing tobacco count as the same as...
Not quite the same, but tobacco's tobacco. We tell people all the same. We say, you need to stop. So that brings in oral cancers and other issues that we talk about too. So really it's going to be, if there's an issue, go see your doctor. And try to get it worked up. And if you, a lot of times what we do is we tend to kind of focus on, well, I don't know, I feel okay, it's not that big of a deal, I'll see my doctor next year, and we push it off. And this is really one of those things where the sooner we catch it, the better. Sometimes us just talking to you, going through your risk factors, seeing if you would be a candidate for a CAT scan or something to get some workup would be appropriate. Sometimes we could say, no, we don't think that you have high enough risk factors. We don't need to worry about it right now. We'll keep a close eye on you. And that peace of mind can help you feel better that you're not missing something or putting it off.
Yes, absolutely. Gosh. Well, we actually have a question here, so I want to go ahead and address it right now. So someone wants to know how they can make an appointment or get a referral to you specifically.
So, good question. So we'll include some information on the Facebook site about my office address and phone number. You can call in and schedule an appointment anytime. We're usually pretty good about getting you in quickly. The other thing would be to have, if you're seeing your primary care physician and you're worried about something, I'm always happy to talk to the primary care physicians and counsel them, or sometimes they just like to ask questions. Hey, I have a patient that has this couple of, these few risk factors. Do you think it would be appropriate to see them? I'm always happy to talk to them about that. So either through your primary care physician, or feel free to contact my office directly and I'm happy to see them.
Yes, we'll definitely put that information in the comment section. And so I just want to thank you so much for joining us today. And thank you for those of you who've tuned in today. Please join me next month when we will be speaking with Dr. Matthews on robotic surgery for colorectal cancer. Have a great day.